This module will guide you in how to use the assessment of reasoning tool to assess a learner's ability to collect clinical information in a hypothesis-directed manner. Generally, histories should begin with an open-ended question, such as, "What brought you in today?" to encourage the patient to tell his or her story. The clinician then uses more directed questions to obtain a detailed characterization of the symptoms, using subsequent questions to test diagnostic hypotheses. An inefficient approach to diagnosis is to conduct a history and physical exam without a specific diagnosis in mind. Examples of this may include a rote review of systems or an undirected head-to-toe physical exam. In contrast, hypothesis-directed history and examination is focused on leading and important diagnoses, follows a logical path, and is modified as the data support or refute potential diagnoses. For example, if endocarditis is an early diagnostic hypothesis, a clinician should describe the presence or absence of embolic phenomenon to support the hypothesis. Similarly, a suspicion for hyperthyroidism should direct a clinician to describe the thyroid exam. As a learner presents a case, an evaluator should follow the learner's line of questioning to see if the learner recognizes the significance of historical clues and how they increase or decrease the likelihood of diagnostic hypotheses. Let's look at a case now to show you how to use the ART to assess the data collection of a learner. The learner is presenting a case of right upper quadrant pain. The following is an example of hypothesis-directed data collection which you would mark as complete on the ART. Your learner gives the following report of a patient.
Maria Jones is a 46-year-old woman with right upper abdominal pain for 2 weeks. The pain comes on suddenly, a few times a week, and lasts for an hour or so. She has nausea but no vomiting. Her pain is worse after meals, but antacids and changes in position do not affect the pain. It doesn't radiate to the back. She denies difficulty swallowing, chest pain, and black or bloody bowel movements. She does not drink alcohol or use any NSAIDs. On exam, her vitals are normal. She is anecteric, her abdomen is soft, but she is mildly tender in the right upper quadrant with no rebound or guarding.
The learner presents the history and physical in a clear, logical sequence that reflects a hypothesis: biliary colic. Pertinent signs and symptoms that are helpful in supporting or disproving biliary colic are specifically included. Information relevant for competing diagnoses, for instance, variation in pain with position change or risk factors for ulcers or pancreatitis, is shared. Her differential diagnosis has not yet been articulated, but can be anticipated from the findings that she mentions. This is an example of a low performer which you would mark as minimal or partial on the ART. Your learner gives the following report of a patient.
Maria Jones is a 46-year-old woman with right upper quadrant pain for 2 weeks. She has tried acetaminophen and antacids without relief. She hasn't fallen or had any injuries, no back pain, and no shortness of breath. On exam, cranial nerves are intact, heart has no murmur, her abdomen is soft without masses, and bowel sounds are normal. Murphy's sign is negative. Her patellar reflexes are 2+ bilaterally.
The key observation for the ART is that the history and examination are presented without a logical organization that reflects a leading hypothesis. The listener is not being led toward or away from any particular diagnosis. A teacher can help the learner collect hypothesis-directed information by establishing the relevant differential diagnosis. This can be modeled or sought by questioning and then guiding the learner to understand what history and physical exam elements are relevant to each of those leading considerations. In summary, obtaining the history using a large predefined list of questions and performing on a physical examination of systems unrelated to the patient's complaint is inefficient. Hypothesis-directed data collection both requires and refines clinical reasoning skills.